which is Adherence Support Coalition to End TB, Digital Adherence Technologies to Support Patients on TB Treatment, South African Results. I will now hand over to my colleague, Mthokozisi Dube, to introduce our speakers for today.
Good morning. Thank you, Nolwazi. On the lineup today, we have Nontobeko Ndlovu. She is a senior program manager at Oram Institute, leading the implementation of TB preventive, diagnostic, and treatment research since 2011. She holds a master's degree in molecular medicine and hematology, a postgraduate diploma in public health, and is currently a PhD candidate in health innovations. Her passion is innovative, pragmatic TB research that translates to progressive policies that improve patient care and strengthen health systems. Nontobeko and her team trained more than 800 Department of Health TB staff in the implementation of digital adherence technologies from 2021 to 2022 under the ASCENT project in South Africa. We also have Tanyara Dube, a junior research manager at the Oram Institute. She holds a master's degree in demography and population studies from the University of the Witwatersrand and postgraduate diploma in monitoring and evaluation from Stellenbosch University. She is currently pursuing a PhD in public health at the University of Witwatersrand, and her doctoral research is on effectiveness of digital adherence technologies among people with rifampicin-resistant TB. She has experience in TB implementation research and has provided support to the South African National TB Think Tank Secretariat as a coordinator. She's currently working on the ASCENT study, responsible for research coordination and management. We also have Professor Salome Charalambas. She's an associate professor and a group chief scientific officer at the Oram Institute. She holds a medical degree from Wits University, an MSc and PhD in epidemiology at the London School of Hygiene and Tropical Medicine. She has a vast experience in medical research in the fields of HIV and TB. She was involved in HIV program implementation prior to ARV therapy implementation in the mining industry and was instrumental in the first large antiretroviral implementation project in the Anglo-American companies. Following that, Prof. Charalambas was the main recipient of a large PEFA grant, which involved HIV program implementation in settings with private practitioners, public health sector hospitals such as Chris Hani Baragwanath Hospital, and Tembisa Hospital, and the Department of Correctional Services. She has been part of program implementation as well, with a number of studies and research articles that have been published. We have Dr. Noria Maraba, who is currently a scientist at the Oram Institute and has been involved in TB and HIV implementation research for over a decade. She has experience in implementing TB and HIV studies in the mines, communities, and primary healthcare facilities. Her research interests are in linkage and retention into TB care, as well as the use of digital technologies along TB care cascade. We have Dr. Finn McQuaid, who is an assistant professor in infectious disease epidemiology at the London School of Hygiene and Tropical Medicine. It's also a TB modeling and analysis consortium secretariat epidemiologist involved in developing guidance and resource for country-level TB modeling to support decision-making and facilitate coordination between international funders and stakeholders. It's also a member of the TB modeling group researching TB treatment and care, including drug resistance and the impact of crisis on TB. We also have Dr. Nicola Foster, who joined the London School of Hygiene and Tropical Medicine in 2020, following research posts at Lancaster University at the University of Cape Town. Prior to that, she had worked as a pharmacist in rural communities of South Africa before focusing on research and the evaluation of population-level interventions. Between 2019 and 2022, she was a member of the South African National TB Patient Costs Technical Advisory Group. So these will be the presenters for today, and this will lead straight to the presentation as our presenters take it over. Thank you.
Thank you very much for the introductions, Thokozisi. So we'll get right on with it. So thank you for affording us this opportunity to share with you the results of South Africa, the ASCENT, under the ASCENT project. As Thokozisi has alluded, ASCENT stands for Adherence Support Coalition to End TB, and we looked at digital adherence technologies to support patients on TB treatment. I must just mention that the ASCENT project is made up of a consortium of partners, which include KNCV TB Foundation, PATH, the Oram Institute, and the London School of Hygiene and Tropical Medicine. An overview of our agenda for today. I'll be giving the overview or the introduction of the project, and then I'll be followed by Dr. Noria Maraba giving us the effectiveness evaluation, and then Tanya Dube will then give us the qualitative findings, followed by the health economics findings by Prof. Bin and Dr. Nicola Foster, and then we'll close off with the implementations and way forward by Prof. Salome and Prof. Catherine. So our funder for the ASCENT project is the Unit 8, who is an international organization that invests in innovations to prevent, diagnose, and treat HIV/AIDS, TB, and malaria more quickly and effectively. So the project started in July 2019 and ended in December 2022. There was a no-cost extension from January to June 2023, just to complete the research analysis. And we are all aware of the global health dilemma that TB has posed for many, many years. And it's still sad that of those who actually get into treatment, we still have less than 90% achieving treatment success. And we know that successful treatment prevents disease relapse, drug resistance, and forward transmission. And the directly observed treatment strategy is not adhered to and varies, amongst the countries. So DATs, or digital adherence technologies, emerged as an alternative, but there is still evidence gap on the effectiveness under programmatic settings. So the primary objective then of the ASCENT project is to evaluate whether implementing DATs plus differentiated response to treatment adherence, which will be monitored through a web-based platform, can reduce the number of adult DSTB patients with poor end-of-treatment outcomes compared with using the standard of care alone. So we seek to find out if digital adherence technologies would be effective, acceptable, feasible, and cost-effective in our settings, with the ultimate goal of coming up with a scalable, affordable, evidence-based, DAT-informed, patient-centered treatment support package for TB treatment. So just a quick description of what our digital adherence technologies included. We had the main one that was used mostly is the medical reminder box, medical event reminder boxes, which have a compartment for storing the patient's medication. And then it comes with an inbuilt electronic device, which is set up to buzz every time or beep at the time that is specified by the patient that they want to be reminded to take their medication at that time. So then there'll be a daily beep to remind the patient to take their medication. And when the patient opens this box, a signal is sent directly to a calendar in this patient's calendar or an electronic adherence platform that will then show a calendar that is green, meaning the patient has taken their medication for the day. And if the patient does not take their medication, then that the calendar would then remain red. So this will then send a signal to the healthcare provider to, to be alert of this patient, and the system would automatically send an SMS reminder to the patient, which is us going into the differentiated care pathway now. And if it persists, missing the doses persists, this is then followed by a phone call or a home visit by the healthcare worker. So then these digital adherence technologies seem like the game changer, because now we are able to monitor patients without them having to come into the facility on a daily basis. We also tested in South Africa a label, which is a much cheaper method, where we just appended a label on the blister pack, the medication blister pack. And this label had information for the patient to just use their phone to send a code every time they take their medication. And when they send this code, then it will log a green on the patient's calendar on the adherence platform. So then the nurse would know that this patient has taken their medication, and there would be an automatic SMS that acknowledges that thank you for making us aware of taking your dose. Well done for taking your dose. Those kind of messages going back to the patient every time they send in the code to say that they've taken their medication. And if they don't send a code, then the differentiated care pathway kicks in again, where an SMS reminder is sent, or then a phone call and or followed up with a home visit if missing doses persist. So we had 5 countries that implemented the ASCENT project, and these were the Philippines, Ethiopia, Tanzania, South Africa, and the Ukraine. And more than 7,000 digital adherence technologies were made available to these countries through the ASCENT project. And in South Africa, we were able to enroll during the research phase more than 3,000 patients. And we must just mention that after the research phase ended in June 2022, one of the districts, Bujanala, recognized that, hey, I think we think these are really helping us. Can we continue? And post-research, they added another 500 patients to the digital adherence platform. So I'll end it there and allow now my colleagues to take over and tell us more about what were the findings. Thank you.
Thank you, Nonto. All right, so I will be presenting the main effectiveness results for the trial. And I'll be doing this on behalf of the ASCENT investigators. So this is the South African team that worked on the trial and implemented the intervention and also collected data for the research component. So just a reminder that the ASCENT trial, or overall for the ASCENT project, was to implement and evaluate a digital adherence technology system using medication sleeve or label and smart pill box linked to a web-based adherence platform to create a differentiated response to patient adherence among adult DSTB patients in diverse settings in the Philippines, Tanzania, South Africa, Ukraine, and Ethiopia. So in terms of our methods, this was a pragmatic 2-arm cluster randomized trial with the health facility the unit of randomization. And this was implemented in 60 health facilities in Tshwane and Bujanala district. And our population were adults who were with DSTB, which they could have had pulmonary or extrapulmonary TB. And then we also collected end of treatment outcomes from the TB registers. So in terms of how we randomized the facilities, we stratified these by district, and we randomized facilities into either standard of care or DET intervention. And in the DET intervention arm, we further randomized facilities to either the smart pillbox or the sleeve or label arm. And in all those, both these arms, we collected end of treatment outcomes. And for our primary outcome for effectiveness, we looked at the proportion of adults with DSTB with poor end of treatment outcome. And the secondary outcomes were the proportion lost to follow-up during treatment and also time to treatment completion. The way that we rather used our inclusion criteria for participating facilities, we looked at facilities that were willing or capable to participate in the study and also having a minimum of 50 notified DSTB patients in 2018. Again, our population, we were interested in adults who were starting DSTB treatment in the standard of care and intervention facilities during the main enrollment period. For ethical consideration, we provided rather informed consent for using platform and technology in the intervention arm was obtained by healthcare workers. And then for the outcome data from routine reporting, we did not have a consent sought from the DSTB patients in both the intervention and standard of care arms, but our patients were notified of the study in posters at the facilities to afford them the opportunity to opt out of having that treatment outcome data used. The study was approved by the VITS Ethics Committee, the London School of Hygiene and Tropical Medicine Ethics Committee, as well as the WHO Ethical Review Committee. For our sample size, we assumed 60 clusters per arm with 50 to 60 individuals per cluster, with a coefficient of variation of 0.3 to 0.35 for the cluster design, which would lead to at least 85% power for 30% reduction in poor outcome. And our statistical analysis plan was approved by the technical advisory group. We had two analysis population, which was the intent to treat, where all adults starting on DSTB regimen in the main enrollment period, regardless of whether they used a digital adherence technology, were included. And then for the per protocol analysis, we restricted in the intervention arm those starting a DET within 28 days of treatment initiation, excluding those who stopped DET within 112 days. And for the analysis approach, we used a regression model accounting for cluster design and a comparison of the intervention, which was a combination of the pillbox and label arm versus the standard of care. And we also did some pre-specified subgroup analysis where we looked at differences across provinces, urban or rural, age, sex, HIV status, and TB classification. And for in terms of our definition of a primary outcome, poor treatment outcome was based on data abstracted from the TB registers. And we defined a poor outcome as treatment failure, loss to follow-up, death, MDR diagnosis, or change to MDR treatment regimen more than 28 days after treatment start. And then a successful treatment outcome was either cured or completed treatment. For individuals with end of treatment outcome missing or transferred out or not evaluated, we excluded that data. And then moving on to our results, as mentioned, we had 60 clusters, 30 in each arm. And for our intervention arm, we enrolled 2,548 and 1,950 in the standard of care. And we had exclusions such as those listed in the light gray box, where it could have been either due to diagnosis change to not TB, or they were transferred out within 28 days of treatment. This therefore left us with an ITT population of 2,494 at baseline for our intervention and 1,880 for our standard of care. We also had additional exclusion for those that did not use the debt, which were 660, and this led us to have a population of 1,556 at baseline for our per protocol analysis. So if you look at our baseline data for ITT population, as mentioned, we had 30 clusters. In terms of number of individuals per cluster, we had 74 in the intervention arm and 61 in our standard of care. Majority of our variables were similar across the both arms, with differences in those with prior TB, which were 16% in the intervention and 12% in our standard of care. For treatment outcome by intervention group, we had 13% of people that were cured, that had a cured TB treatment outcome in the intervention arm and 9% in our standard of care. 71% had completed that TB treatment in the intervention and 78% in the standard of care. And then for loss to follow up, we had 6.7% of our population in the intervention arm and then 5.2% in our standard of care. So moving on to our primary outcome of poor outcome in the intention to treat population, we see that we had people in our intervention arm were more likely to have a poor outcome, but this again was not statistically significant compared to our standard of care. And this was after we had adjusted for randomization strata. It was still the same if we had included randomization strata, baseline imbalances, and intervention versus standard of care. And the graph that you're seeing now on your screen is just showing percent of poor outcome, and the dots here indicate the different health facilities that were enrolled in the two arms. And as you can see, there are no differences between the two arms. And then move on to our secondary outcome of loss to follow up. Again, we had patients in the intervention arm being more likely to be lost to follow up, but this again was not statistically significant as it was crossing one. So we also did a subgroup analysis to look at our primary outcome adjusted for randomization strata only. Again, you look at the analysis and we can see that for all the subgroups analyzed here, there was no difference between them, as all of them were crossing one. So for the primary outcome of per protocol population, the results were also similar to the ITT one. There was no difference between the two arms. It was also the same with the loss to follow up outcome with 1.13 odds ratio, but again, this was not statistically significant as it was crossing one. Our 95% confidence was crossing one. So in conclusion, the rate of poor treatment outcome did not differ by intervention arm in both the ITT and per protocol populations. Also, our subgroup analysis did not yield any significant difference between the two arms. Other studies show mixed results, but our study concur with findings from recent large cluster randomized trials like the TB-MATE and the trials done in China, where although there was a difference in the adherence in adherence in the studies, but there was still no difference in the TB treatment outcomes between the intervention and control arms in those trials as well. So in terms of future direction, results from the accompanying sub-studies, which take both client and provider perspectives, should be considered in consideration for policy decision on digital adherence technology use. And we would just like to acknowledge the National Department of Health and the Northwest and Gauteng provinces, as well as the Bojanala and Tshwane district, our health centers and the clients, Community Advisory Board, as well as our funder, Unit 8. Thank you.
Thank you, and I think it's onto the health economics next. So I'm going to give a very quick overview of some of the health economics that's happening in ASCENT in general and in South Africa in particular. So I just wanted to start by defining what we're talking about here. So when we're looking at something, trying to find cost effectiveness, then what we want to find is the incremental cost of an intervention and the incremental effectiveness. Here, we've just heard from Noria about the incremental effectiveness. And so we're going to talk a little bit about what the costs are involved. You can break the cost down into different components there. So you can think about the cost to the patient of the intervention, also the cost to the provider, and the cost of the intervention itself. So when you're talking about the cost of the intervention, you're thinking about things like the cost of the technology, the cost of these medication monitor boxes, the cost of training healthcare workers in their use and so on, and of support in providing that training and setting this up. When we're talking about the cost to the provider, we're thinking about the additional human resources, the change in what this means for healthcare worker time, the cost of drugs and diagnostics, the cost of home visits made and overheads and so on. And then lastly, when we're talking about the patient costs, we're thinking about the out-of-pocket cost to the patient and also, of course, the time that the patient spends as a result of this intervention, how that changes. So lastly, we also need quantities in terms of things like the number of visits that are made, the number of days that are spent on treatment, the number of tests that are used, and so on. So in ASCENT as a whole, we've got different portions of these costs from different countries. So Nonto mentioned in the beginning that this is across 5 different countries. So the intervention costs, for example, we have across all 5 of these different countries, and I'll just outline in a second what exactly that looks like. For the patient costs, then Nicola, when I've finished, Nicola will talk about the patient costs, which are collected. We have these for 4 countries, which she'll present some results on in a moment. And then lastly, for all of these together, so for the provider costs, as well as the patient costs and intervention costs, Nicola has also done a lot of work on these in Ethiopia in particular, which we will not go into detail in here. So in South Africa in particular, we do have these incremental effectiveness results, which we've just discussed. We do have the patient costs and we have the intervention costs. We won't be producing cost effectiveness results. Because we don't have these provider costs, but we will have these other costs for a subset of patients, and we'll use these to think about cost thresholds for the intervention and so on. So just to mention, as I said, I'll go through the intervention costs, and then Nicola will talk about the patient costs. So the intervention costs is something that Dr. Lara Ghosh has been working on. So these are split, I mentioned earlier, into 3 different broad areas: the cost of the technology, the cost of support for setting up the intervention, and the cost of training as well. In terms of the cost of technology, we're thinking about the cost of purchasing the technology, the cost of shipping, infrastructure, SMSs when setting this up, and so on. In particular, in South Africa, we note that WisePill, who produce these medication monitor boxes, are based in Cape Town, so this obviously reduced some of the costs there. And labels for the labels arms of the intervention are often printed locally, so that also reduced some of the costs there. In terms of treatment support, we're thinking about things like visits and calls. These are from to healthcare workers from Aurum in this instance to resolve queries and to help set this up. So rather than from the healthcare workers to the patients, it's in terms of setting up the intervention. And then lastly, training costs, we're thinking about things like staff salaries for trainers, but also for the trainees, how much time is spent doing this training, what the venue costs are, accommodation, transport, food, and so on. And this in particular depends on the number of interns who are trained and the costs of venue, which are important in South Africa in this context. Just to say that I'm not going to be presenting results for this now, but the results for this will be coming quite soon. And I just wanted to end by saying thank you very much to research managers in all of the various countries and to KNCB head office. And I'll pass over to Nicola now to talk about the patient incurred costs. Nicola, I can control the slides.
Here we go. Can you hear me okay now? Oh, great. So I'll be speaking just briefly on the patient incurred costs for individuals using DATS to support TB treatment adherence. And as mentioned before, so this presentation was actually given at the Union Conference last year in November 2022. And we collected patient costs for 4 of the ASCENT countries. So we collected patient costs in South Africa, Ethiopia, the Philippines, and Tanzania. So the interviews were conducted in 2022, and a total of 388 trial participants, adult DSTB patients, were interviewed. These were cross-sectional patient cost surveys, and they were conducted in 10 trial health facilities in each of these 4 countries. We aim to interview 10 trial participants per health facility from the intervention arms, and participants were purposefully selected based on their gender and treatment phase. Total episode costs were calculated by estimating the cost per treatment phase and then imputing the average cost per patient at the same health facility for the corresponding treatment phase. I think, as was mentioned earlier, time spent was valued using the average wage rate of government employees or country minimum wage, depending on the country for which we were doing the analysis. All costs were assessed in the local currency and converted to 2022 US dollars. So moving on to the demographics, so I'll briefly speak through these. So as you can see, for each country, so in Ethiopia, 100 individuals were sampled, South Africa 84, Tanzania 100, and the Philippines 104. Looking at the age distribution, so patients in Ethiopia were slightly younger than in the other 3 countries. Gender was largely matched except for South Africa and Tanzania, and it was partly because of how the sampling was conducted. Looking at number of household members, that was very similar between the countries. And on looking at treatment phase, patients interviewed in the intensive versus the continuation phase. So in the Philippines, we had a larger focus on the continuation phase, but for the other countries, including South Africa, about 36% were interviewed during the intensive phase of treatment and 63% during the continuation phase. Types of adherence support, in South Africa, we slightly sampled more people in the labels arm. And looking at self-reported income, so this was one of the measures that we used to value people's time. The proportion of participants who reported no individual income was 14%. In Ethiopia, 21%, in the Philippines, 17% in South Africa, and 34% in Tanzania. So in South Africa, the average monthly self-reported income for patients interviewed was 169 US dollars. And when we looked at classifying these patients based on their self-reported income into tercile, so least wealthy, middle, and wealthy patients. So we found that in the South African population, so the average income of self-reported income was about 432 US dollars if they were considered wealthy, $92 if they were in the middle, and about $9 if they were per month if they were in the least wealthy or the poorest group. So looking at the total patient incurred costs. So the slide on the left shows you the total patient cost per person in US dollars, and on the x-axis the countries. So I'm not going to go into a comparison necessarily, but if you look for South Africa, the total patient costs were fairly low, and if we compared against income, so with various ways of looking at income, then it was approximately 14%. So the out-of-pocket costs incurred was about 14% of patient income. Okay, so then on the right-hand side, on the next graph, so looking at for each of the countries as well, looking at where these patient costs were incurred. So whether they were incurred by the poorest households or the wealthiest households. We see similar to what we would expect and what we find in theory, that the least wealthy households were experiencing lower sort of absolute amounts of patient costs than the wealthiest households. But we found that the households in the middle tend to incur the most costs. And then I think our last slide is just an acknowledgement slide.
So I'll be presenting the ASCENT qualitative findings. My name is Tanya Ratsbatube. Just as the background, in ASCENT, 2 digital technologies were implemented. One of them was with the smart pill box, which has a medication storage area, and it has a reminder buzzer, which reminds participants to take medication every day at the same time when the alarm buzzes. And the box also had a reminder light, which would remind our participants to go for clinic refill visits. And as soon as the participants opened the box to take their medication, a signal was digitally sent to an adherence platform to notify the healthcare workers that a dose was taken. The second technology was the labels, also known as the 99 dots version. This is an SMS-based strategy. So with the labels, participants were expected to send an SMS, a free SMS to a code every day after taking medication. For example, they would send 775 to the number 42352 daily. And soon after sending the SMS, they would receive an acknowledgement SMS thanking them for taking their daily dose. And as soon as also they sent the SMS, a dose was digitally recorded on the platform. So this is the adherence platform that was being viewed by the healthcare workers. The green box indicates the days where the participant either used the box or the labels as a proxy for medication taken. The red box indicates the days where the technology was not used, hence the adherence platform did not receive any signal, and there was a proxy for missed doses. And when there were missed doses, the differentiated care would kick in. And with the differentiated care, if a participant missed a daily dose, they would receive an SMS reminder. If they missed 2 to 3 consecutive doses, they would receive a phone call from the healthcare worker or assistant. And if they missed 4 or more doses, they would receive a home visit and motivational counseling. So the aim for the qualitative sub-study was to explore the acceptability and feasibility of implementing a DAT, which means digital adherence technology intervention and differentiated response to patient adherence from the perspective of people with TB, healthcare workers, and stakeholders. In terms of the methodology, we conducted this qualitative sub-study in the areas where we did the DSTB trial in Bujanala and Tshwane districts. The study population was adult DSTB participants who were enrolled during the research phase and were on TB treatment. We purposefully sampled those who had documented good adherence according to the platform, those who had differentiated care initiated, meaning there were some days they missed doses according to the platform, and those who opted out of using DAT, meaning they withdrew from the main trial. We also purposefully sampled healthcare workers and stakeholders. We conducted in-depth face-to-face interviews using an interview guide. Interviews were audio recorded, transcribed verbatim, and the duration was ranging from 25 minutes to 120 minutes. So we piloted the interviews in March 2022, and the main interviews were conducted between May 2022 and March 2023. The interviews were conducted in languages the participants preferred. The interviewers were trained research assistants, Youth Health Africa intern, study coordinator, and the research manager. In terms of the findings, in total, we interviewed 68 participants. 35 of them were people with TB and 33 were the healthcare workers. So out of the people with TB, 57% were males, 34% were non-adherent, 57% were adherent, and 8% had opted out. 57% used the box. 20% had used the labels only, and 23% had switched from the label to the box. In terms of healthcare workers, we interviewed TB nurses, community healthcare workers, general worker, treatment supporters, interns who were supporting the healthcare workers, district stakeholders, and the provincial stakeholder. In terms of the findings, we found 4 major themes: facilitating factors of DAT and differentiated care, barriers to using the DAT and differentiated care, perceptions of DAT among healthcare workers and stakeholders, and the necessary conditions to scale up the DAT. In terms of the facilitating factors for the smart pill box and differentiated care, participants reported that there were favorable features of the box which were acceptable. This included that it was easy to operate for all ages and there was an audible alarm reminder. For example, this participant said, "I found it simple because I follow the box rules. When it alarms me at 7, I must drink my medication." Other features included that it was portable, there was a clinic visit reminder, there was storage of TB and other medication, the long battery life because it would last for 6 months if it was fully charged by the time the participant received the box, and there was no need for the participant to have a phone if they were using the box. The second facilitating factor we found was that they appreciated the social support from family, co-workers, and community. So they were supporting the idea of using the digital adherence technology, and some family members would bring the box to the participant if the alarm rings when they are not close enough for them to hear it. And participants also reported that differentiated care improves person-centered care. The people with TB felt supported by the SMS, phone calls, and home visits. Most preferred action differed across the participants, which shows that differentiated care is important. In terms of the barriers of the smart pill box and differentiated care, there were also some features which were found to be unfavorable. Some participants found the box to be not portable, and some reported that the alarm was noisy and it was making noise for their family members. For example, one participant said, "Yes, it would awaken people and make noise when they are asleep." There was also perceived stigma with the use of the box and differentiated care. For example, with the home visits, some participants reported that they did not want home visit because of the stigma. Other participants experienced a malfunctioning alarm. It would either ring at the wrong time or multiple times, and this led to some of the participants withdrawing from the main trial. And there were also some who experienced SMS glitches where they would receive reminder messages even though they had taken the medication using the technology. In terms of the facilitating factors for the labels and differentiated care, there were also some favorable features of the label. Participants reported that it had privacy and it was portable because it was a matter of carrying a blister pack with that sticker and having a cell phone. And the young found the instructions easy to follow, and participants also appreciated the acknowledgement SMS they would receive after sending the SMS. For example, one participant said using the labels was very helpful because you'd get an SMS saying, "Thank you for taking your medication. So it's good, you feel great." Participants who used the labels also echoed the importance of social support when using digital adherence technology. Some of them were assisted to send the SMS. Participants who also used the label also found differentiated care, improving the person-centered care, and the most preferred action also differed across the participants. In terms of the barriers of the labels and differentiated care, we found that some participants were not able to send the SMS because of old age and illiteracy. Others were not able to do so because they didn't have an access to a phone because it was lost, damaged, or they were sharing, and by the time they take medication, the person they share the phone with won't be around. Some participants lacked understanding of why they need to send the SMS after taking the medication. For example, one participant said, "I would say there's no use to send the SMS because I drank my medication, you see." Other participants forgot to send the SMS. There were also issues of electricity cut-offs, which affected phone battery charging and the network. There were also technical glitches that were reported. For example, the code was not going through, which led to excessive reminder messages. And even though the SMS was free, some service providers required the participants to have a positive airtime balance. And if they didn't have airtime, the SMS would not go through. And other participants ended up switching to using the box because of these barriers. So the positive experiences of the digital adherence technologies among healthcare workers and stakeholders were that it was easy for them to use the adherence platform. The digital adherence technology improved their working conditions. They reported it would save time. For example, instead of looking for a patient file, they could easily find some information using the system at hand. And it also saved resources, for example, to do community dot. The DAT allowed early intervention because they would see the adherence in real time and intervene accordingly. Healthcare workers also echoed that the digital adherence technology and differentiated care improved the client healthcare worker relationship. And they reported that implementing the box was generally easy. For example, some healthcare workers reported they were even assisting some homeless participants who were able to complete their treatment using the box with no problems. Healthcare workers also appreciated the support they received from the intern. We had interns assigned to each intervention facility. In terms of the negative experiences, some participants, some of the healthcare workers reported that other participants used the technology but not taking the medication. So they would find out when the participant presented themselves at the facility, and they will see the participant not clinically improving, yet the platform showed good adherence. Healthcare workers also reported the difficulties in implementing the labels due to the individual, contextual, and technical challenges. They also reported that the DAT was also difficult to implement amongst some groups, which are drug users, though this was a very small group. And healthcare workers also reported stigma concerns, and they perceived that one of the reasons why some of the people with TB declined to participate in the study was because of the fear of stigma. And they also reported that the fear of stigma also affected the differentiated care in the sense that some participants would provide incorrect contact details, wrong home addresses, wrong cell phone numbers because of the stigma. In terms of the necessary conditions to scale up the technology, we found that healthcare workers would want the implementation of digital adherence technologies to continue, but there will be need for human and financial resources. There was an intern assigned at every facility, and that person should also be there should it be scaled up. And healthcare workers and stakeholders also recommended integrating DATs with existing systems, for example, the TIA.net. In conclusion, we found that even though there were factors inhibiting the use of the box, some of the participants found most features acceptable. And also, even though the use of the labels was acceptable to some participants, some experienced structural and individual challenges and ended up switching to using the box. And to address the issues of portability with the box, people with TB could be offered different sizes of the box. We also found that healthcare workers found the DAT implementation acceptable and feasible, especially the box. And further work is needed to make DAT and some of the differentiated model of care components less stigmatizing. For example, not wearing uniforms when conducting home visits and increasing TB awareness in the communities. I would like to thank the study participants and health center staff, the Department of Health, Northwest Gauteng, Bojanala and Tshwane District, the Community Advisory Board of the study, and also the ASCENT Oram team that was led by Ms. Nondobe Bondlovu. Thank you.
Thank you. Up next, Prof. Salome Charalambas will give us the concluding remarks, dissemination implications, and the way forward. Prof. Salome.
Cool. Let me just check whether I've actually loaded the right slide. Let me just, yeah, okay, thank you. I'll talk to them. So just to say, I'm just going to, just looking at what we learned through ASCENT. So next slide, please. So what do we know from ASCENT? So what we've found is that the DATs, unfortunately, they did not seem to improve treatment outcomes, you know, through the trial that we did, as was currently measured, but they also didn't do any harm. We also saw that patients and providers find the intervention acceptable and that they felt that this improved support to patients to be adherent. We have also demonstrated feasibility on a large scale, as was indicated. This was a very pragmatic study, very large number of clinics that were involved and very few staff members that actually supported the clinics. And then we also know that the intervention on the patient's costs will be important for future decisions on the use of DATs in routine care. Next slide. So what do we think about when we look at the future? We can maybe think about whether DATs would be an acceptable alternative to DOT. We know that in South Africa, generally, you know, DOT at facility level has been abandoned, but is this a way to still try to support people who are taking TB treatment without forcing people to spend lots of time in health facilities? Also, another issue is, are patient outcomes, are there other patient outcomes that are important for assessing DATs? We know that 2 large trials have shown improvement in adherence, but didn't show improvement in patient outcomes. Is it that maybe adherence is, you know, also important, and that the DATs do improve adherence? That's still something that we don't know. Other outcomes, such as long-term outcomes or long-term disability, is also unknown at the moment. It will be important to understand routine provider costs for future decisions on the use of DATs in routine care. And there also needs to be some thinking about how the implementation could be done, what would be the approaches that would work in our environments. Also, something just to think about is, as we go to new, shorter regimens for drug-sensitive TB, will adherence maybe be more important than it is right now in influencing patient outcomes? And would there be a role for DATs there? And what about drug-resistant TB regimens? You know, can DATs maybe ensure adherence in drug-resistant TB patients? And there is some work that's still part of the ASCENT trial that will be, will be done on people who were receiving DR TB treatment and were using these DATs, and we will be reporting on that in the future. Then just to conclude in the next slide is that we are presenting some of these results at the World Conference on Lung Health in Paris in November. There will be a symposium on the impact of digital adherence technology on TB care. So please come to that if you are going to be in Paris. And then there'll also be another satellite symposium on digital adherence technologies in TB care. We also been working with a global data. The ASCENT research portfolio has already contributed to a report of the WHO consultation on digital technologies for TB, and the ASCENT research portfolio will contribute to the global DAT task force. And then, of course, we are planning to publish all of these results, so look out for some of them. Then on behalf of the whole team, just to thank everyone for your time, for coming to this webinar, and we look forward to your questions. And you know, if you can send them in the Q&A. Thank you.
Thank you so much, Salome. Nolwazi will take over now for the Q&A.
Thank you so much, Ntogo. Thank you so much to our speakers. As Prof. Salome has mentioned, please do enter your questions or comments under the Q&A tab at the top. So for now, we have a question that asks that given that 20 males were interviewed and we find low adherence in males, what were the outcomes? Any of the speakers can respond, and please do so with your camera on.
Maybe Tanya, you can maybe Tanya can respond to why we only interviewed 20 males, but there were not only 20 males enrolled in the study. I think around 3,000, and around 60% were men. But for qualitative studies, we usually choose a smaller group of people because it's a more intense investigation. People are asked a number of questions, so usually that's done on a smaller sample. Tanya, do you want to speak to the 20 males?
Yes, and the males were actually the majority amongst the people with TB who were interviewed, because we interviewed a total of 35 and 20 out of the 35 were males. And in terms of the qualitative findings, we did not find any gender differences in terms of what they were reporting. Thank you.
Thank you as well, Tanya. On that, I think it's a follow-up. They're asking, was there any psychosocial support provided to these families?
Not as part of the ASCENT project in the DSTP, but we also implemented a DRTP component in the city of Cape Town, and there was also a psychosocial, but not in the DSTP trial we just presented.
Okay, thank you for that, Tanya. Colleagues, we have about 2 minutes left for any questions that you may still want to enter. Do we perhaps have any other comments or remarks that the speakers would like to add before we close off? We have a few minutes left. Okay, whilst we wait for any closing remark or comment or question, also please be reminded that if you'd like to be on this platform in the coming months, please do email myself on the email address that you see on your screen now. If you'd like to be on this platform in the upcoming months. I think we have time for one last question shortly. It is still loading. So this question goes, in the consort diagrams, it appears that a lot of people offered DAT, never used it, and were not included in the analyses. How did that impact the results? How did that impact the results? Were they similar to those included in the analyses?
Okay, I can answer that one. So you'll see that there were two types of analyses that were done. There was an intention to treat analysis and there was a per protocol analysis. So the intention to treat analysis is where you actually include all individuals that are at the facilities, the people at the facilities randomized to the intervention arm are compared to the people randomized in the control arm, regardless of whether the person opted to take on the intervention or use the intervention. So that's the main analysis, the intention to treat analysis. But we also did do a per protocol analysis, and what the per protocol analysis does is that it only includes people in the intervention arm who actually took on the adherence intervention, and then compares them to everybody in the control arm. So in both analyses, the results were very similar. So whether we use the intention to treat analysis or the per protocol analysis, the results were very similar. I hope that answers the question.
Okay, thank you, Prof. Salome, for that answer. We have reached the end of our session today.
Sorry, I see,
yes.
Nwazi, I see there is one more question. It would be nice to answer that if we can.
Okay, which one is that one? The first or the second one?
It says, given the fact that these devices did not improve adherence, are they worth the financial investment given competing financial priorities? Why can't we take the money and put it towards addressing, and I can't read the rest, addressing the social determinants that are driving loss to follow up? I think that's a fantastic question. So just to try and answer that. So I think, you know, we have to think about, as you say, there are competing priorities, and that is why we are doing the economics analyses and trying to understand the costs. One of the things we do need to see is that, you know, are the outcomes that we are measuring the correct outcomes? You know, at the end of the day, we are only saying a person completed treatment and we're calling that treatment success. And if adherence could be better, even in those people, then that might still be worth the effort, because in the long run, they might have better outcomes. So we're still trying to understand all this really well. Social determinants are important, and of course they are, but you know, one has to think about what are those social determinants that are driving loss to follow up, such as poverty and you know, inequalities in the system and so on, and the cost of the DAT is not going to come close to the cost of those things. So, you know, it is a balance, and we do need to think about all those balances. But if you think about what are the social determinants that drive loss to follow up, very many of them are very difficult to deal with. You know, one thinks of things like alcoholism and drug addiction and so on, and that sounds like it's something that needs to be addressed, but just think about how easy and whether it is easy to address those things. So those are some of the controversies around at the moment, you know, what people are trying to discuss and trying to understand. Thanks.
Thank you for your answer, Prof. Also, please note that the other questions that we didn't get to in the interest of time will be responded to. I would like to thank all our speakers for today for their time, as well as everyone else in attendance, and enjoy the rest of your day and see you next month. Thank you.
Thanks.